So we will shift the topics out of the lungs to the bronchus. First, I would like to thank the organizing committee, especially Harry, for inviting me to this great conference. So my task is to talk about tracheobronchial tuberculosis. Have no conflict of interest. First, we have to start with the definition. Tracheobronchial tuberculosis, you can make a diagnosis from the histologist examinations of the bronchoscopic, obtain specimens showing granulomatous inflammation or the positive acid-fast bacillized by cultures. The prevalence is around 10 to 40% of pulmonary tuberculosis. But the cause of the disease is highly variable. This is the examples of the biopsy specimens. So pathogenesis, it's supposed to first direct spread of the tuberculosis bacilli from parenchymal tuberculosis or cavitary lesions which contain abundant tuberculosis. All disseminations of tubercle bacilli from peribronchial lymphatic channels, the draining pulmonary tuberculosis, or spreadings from contiguous mediastinal lymph nodes to the bronchial mucosas. Lastly, it can directly implantations of inhaled Mycobacterium tuberculosis into the bronchial wall mucosas. Patients can come in with two forms. Firstly, they had active disease, which is the active caseating material oscillations of granulations tissue formations with the histology finding of caseous necrosis and positive tuberculosis bacilli. Or they may come in with a fibrotic disease, with the fibrosis seen on bronchoscopic view or biopsy confirmed without positive acid-fast bacilli. We all know that left main bronchus has most frequent involved because of the anatomical compressed by the aortic arch, or it's made longer, and the left pedestal lymph node infected faster than the right side. In terms of the diagnosis, if the patients came in with a female, younger, came in with a cough, weight loss, and hemoptysis, chest pain, and dyspnea, so we consider they might have enterobronchial tuberculosis. And the common coincidence with parenchymal disease, usually it's young girls. They can be misdiagnosis for asthma with the wheeze. The sputum FV positive is around 13 to 50%. The skin test is positive around 60%. If the interferon gamma release assay was done, the sensitivity is only 64%. The upper airway needs to be narrower than 8 millimeters before the symptoms happen. So in that, the peak flow will decrease to 40% with airway resistance increased. And FEV1 still at 75% predicted. So the PFT can make us diagnosis late. Also, the chest X-ray can be normal in 10%, but mostly you can find pulmonary infiltrations. In the old studies found 60% of the parenchymal infiltrations with 24% lost volumes. You can find post-obstructive pneumonia and also atelectasis. CT scan can show you a lot of information in terms of the extent, length of the airway involvement, and parenchymal distal to the involved bronchus. You have to differentiate the active from fibrotic stage in which CT scan can guide you, like you see the airway wall. If you can appreciate the airway wall, if it's thick, it can be the active disease. Also, the parenchymal lesions, if it's more peripheral infiltrate, it should be guide you to the active disease. If the wall thin, you can say that it might be the fibrotic stage. This is CT scan features that predict the outcome of the interventions. If the patients have parenchymal calcifications or bronchiectasis, it will lead to the failure. It means that it looks like if you have damage of the parenchyma, also the longer infected before, it leads to the failures of the treatments. Like in these patients, you can see the thickening of the left main that was collapsed, and also the collapse of the left lungs. And by pay attention to the lower lobes, the lesions that you see, this is not a bronchiectasis, it is just mucus in the bronchi. So in these lesions, when they put the stent in, the left lung can completely ventilated. In this case, you can see the calcifications and also the atelectasis of the left lungs, and even they can demonstrate the losing of the left mains, and after they collected with the stent, the lung doesn't have good re-expansions. This is a famous articles from Chung from Korea that demonstrate to us the different morphologies of the endobronchial tuberculosis, which you can appreciate that there are many groups, and you cannot make a diagnosis only from the visualized from endoscopically. The outcome predicted of these pictures, this involvement is changing over time during the treatment. So the lesions will be fixed in 3 months after you started the treatment. This is look like a tumor, and this is a fibrostenotic type, and this is also the fibrostenotic type. This is also the granulation type, and which you can see the parenchymal involvement. This is also the stenotic type, and the tumorous type, which cause the stenosis or the lower lobes. Also, as I mentioned, the lesions change over time. So you can hardly predict it, which patients before 3 months, whether they will go to the airway stenosis or not. In terms of the management, first you have to eradicate tuberculous bacilli and prevent the stenosis. The old studies, they found persistent bronchostenosis after treatment in 41%, especially in patients who had age more than 45, has pure or combined fibrostenotic subtypes at the beginnings, and durations of the symptoms to starting anti-tuberculous drugs more than 90 days. In these studies of Chung's, he found that if you see the lesions in endobronchially showing active caseating edematous hyperemic fibrostenotic tumors, it guides you that patients will develop bronchostenosis in 50%. But if the lesions show granular ulcerative non-specific bronchitis, only 10% develop bronchostenosis. If patients come in with the active stage, you have to control infections and prevent stenosis. In this particular patients, steroid doesn't have any benefit. If patients come in with fibrotic stage, medical treatment has no benefits. You have to give the patients anti-tuberculous chemotherapies for more than 3 months before you evaluated the real stenotic areas. So if you want to do a the patients came in with symptoms, you want to do surveillance, if you found stenosis, you can do a balloon dilatations first, and then evaluate whether you have to put a stent in or not. With the other things that you can do, whether it's a lasers, argon plasma correction, cryotherapy, or ultrasounds to evaluate the cartilaginous structures, depends on the case. Iwamoto, in 20 years ago, he followed 30 patients and find out that 5 in 11 patients success by repeated balloon dilatations. So balloon dilatations alone is sufficient in 30 to 40% of the patients. If you can do radial EBUS and found out that the cartilage is also involved, so it means that you might have to put a stent to the patients. And the recommendations of the stent is silicone because you can move it afterwards. In this big series of 80 patients followed up for 4 years, he found that the trachea size average around 9.5 millimeters with the bronchus size average size around 5 millimeters. They put silicone stents in most of the patients, 94%, and the stenting removal can be success in 54 cases, 72% in 14 months, with the stable of the lesions in 36 months, and 5 require re-stentings. And with the follow-up of 41 months, only 3 patients go for surgical resections. And this is just what we have said. So the case that need prolonged stent placements usually have lower baseline FEV1s, need more interventions, coming with the generations tissues, and restenosis. Only 10% has major complications such as massive bleeding, pneumothorax with no mortality. This is a small series with 7 patients, also show that mostly patients can end up with dilatations and also stents with no mortalities. They can find good durations for stent placements, but the attempt of remove stents occur in 8 to 16 months. This is studies from China demonstrate what is the appropriate sessions for only balloon dilatations, and this is the case. And they found that around 4 to 5 times of balloon dilatations will give you the maximal response, around 81 to 88%. And this is the examples. You can come in with total collapse, and after treatments, the lungs slowly expanded with the stent placed into the left main bronchus. This is articles from Korea, from Professor Ho Chong Kim. He has studies the case that he put the stent in and wants to remove the stents. He has 226 stable patients. 285 cases with the first attempts, and 59 has to be put back the stent in. And he can find factors that relate to successful stent removals. In his articles, the age, if you have older age, older, they are more successful. If you are male you have more successful. If you have parenchymal calcifications, segmental consolidations with broncholymph, so you have less likely to be successful as previous studies. Also, if the lesions is in the bronchi, okay, you have more successful. If the lesions is in the trachea, you have less successful for removal of the stent. And the timing that you have a much successful removal of the stents is around 1 to 2 years. This study can tell you that numbers. Endobronchial tuberculosis in children is very rare, and I can find only these articles which retrospectively studies only 45 cases and 13 cases that have endobronchial involvement, which age around 3.9 years. And only one case, which is a 7.7%, has bronchial stenosis that need balloon dilatations. Others' involvement can be healed and less likely need some interventions. So it's quite rare. And this is the examples of the endobronchial tuberculosis in children, in which they can just remove the clot that and do one case that was done balloon dilatations and successfully. So in conclusions, endobronchial tuberculosis is very difficult to diagnose. You can make guess in patients who come in with unproportional cough from if you see the small lesions in the lungs, but the patient still cough after treatment, or starting to have dyspnea bronchitis from the physical examinations. If the patients come in active phase and no symptoms, even you know that they have endobronchial tuberculosis, conservative management is preferred. You do a lung function after complete treatment and bronchoscopy if indicated. If patients come in with symptoms and active phase, you can do a bronchoscopy, evaluate the lesions, you can biopsy to make sure that it's still active, or if the lesions is severe enough, you can do a balloon dilatation even in an active phase. If patients come in with fibrotic phase and no symptoms, but has lung function impairments, whether you want to do interventions, it depends on the discussions to the patients. If patients come in with symptoms, you do a bronchoscopy, you make sure that it's a fibrotic phase, and then you do interventions, management. If you see no lumens at all, I suggest to consult for the surgeons to do a surgical corrections. If the lesions is simple, mean it's less than 1 centimeter involvement and only one side, especially if it's the web size stenosis. So bronchoscopic interventions is indicated, but in some place you can talk to your surgeons whether they can do it or not. But if the patients come in with multiple lesions or lesions longer than 1 centimeter, you can do a bronchoscopic interventions with dilatations and balloons as needed. Thank you.